So with that, I think we move on to our two global keynotes. And it's a really great pleasure to introduce Torsten Schwede here. Torsten is a chemist by training. He did his training in Germany, did his graduate in Freiburg as a wet chemist doing crystallography and looking at protein structures. And then he came actually for some time into pharma. At that point, he became a dry computational biologist and set up this incredibly successful project that still runs to today, Swiss models, about looking at protein structure models. I think he had a lovely time in pharma, but decided to come back to academia here in Basel to set up the bioinformatics, be head of bioinformatics for Biocentrum, the kind of big Basel life sciences collective. And at that point, Torsten, I think also, sorry, you haven't given up protein structure, have you? But he has expanded also into genomics and into healthcare data, and is a real leader in Switzerland now in getting routine healthcare data in a form for research. So Torsten has been both our kind of local host here, but I have been watching how Switzerland has been putting together its health data and genomic medicine. Torsten's been a leader in that, and that's why we're so happy to see you here, Torsten, to give this talk.
Thank you very much, Ewan, for the kind introduction and for the invitation to present here today. Good morning, everybody. It's great to see the global community gathering here in Basel, discussing enthusiastically about responsible sharing of health data, especially as we're a very young country in terms of sharing health data and genomics initiatives. We didn't have our second birthday even for our initiative here, so it's a special honor for the Swiss Personalized Health Network and SIB to co-host the Global Alliance meeting here in Basel. So for the next 20 minutes or so, I'd like to give you a bit of an overview of what we are trying to achieve with the Swiss Personalized Health Network, as well as what we have achieved so far. Now, in contrast to many of the other initiatives that you might be aware of, SPHN is mainly rooted in research. So we are trying to drive the Swiss agenda from a research perspective, and you see the glossy mission statement there saying that the main goal of SPHN is to bring Switzerland at the forefront of research in the area of personalized health by establishing nationwide interoperability of biomedical information, which of course sounds cool. Everybody has the mission statement. In practice, that's a little bit more complicated. But let's first think why, from a research perspective, that's actually an interesting agenda, and not just from a medical perspective. And that slide, I think you can't see anymore, but the main point here is that we expect in the coming years to have tens of millions of human genomes being sequenced, but all of that, or most of that, in the healthcare sector, not in the research sector. Also, we are starting to track ourselves increasingly in a clinical setting, in a private setting, capturing lifestyle data, capturing physiological data, nutrition. In the hospital, if you go today, everything is captured by sensors, so we are accumulating huge amounts of data, which basically makes human the most interesting model organism for science these days. But that, of course, gives a challenge for the science system. So we so far have been working on the paradigm of translational research, at least at most universities I know, assuming that we're data-rich in model organisms. We can do cell cultures in mouse and rats and frogs, where we have lots of data, and then it trickles down to higher and higher organisms and we translate into clinics. But we're awfully bad in bringing bad real-life data into the research area. And we have to close this cycle to actually have an impact where we benefit from both the richness of the data that is coming on the health side, and on the other side, the analytic competences we have on the research side to make sense out of this data. Now, this Mickey Mouse slide everybody hates, so if somebody has a better one, I'd be happy to change it one day. It tries to summarize too many things in one slide. Namely, what are we trying to achieve with SPHN? So as I said, we have on the right side our researchers that might be highly skilled and interested in analyzing data. On the left side, we have our hospitals that typically, at least in our countries, store their data in little silos sorted by disciplines. So if we want to get the data out of the hospital environment into an IT environment where researchers actually have access, we have to build the process that first brings together the information from the disease or clinic-specific silos into a data lake at the hospital, and from there into a secure environment where researchers can work on it. But of course, not just from one hospital, but we have to bring it together from all the hospitals in the country, and then enrich the data into a background that includes healthy reference data, citizen-reported data, model organisms, and international collaborations. And that all together then hopefully in the end will lead to innovation in the health that feeds back either directly into the health system or into other forms of new targets, new therapies, new interventions. Now let's reflect this into reality. What does that mean for Switzerland? When it comes to health data, also in other aspects, but especially there, we're a hell of a complicated country. It's only 8 million people, but it's a confederation of 26 different cantons, each canton having their own legal system for the health care and their own data protection laws. So we're something like a mini Europe in a very narrow space. Same languages. So we're dealing with at least 3 languages that are relevant, German, French, Italian, but then of course there's the occasional Romansh and there's the occasional English, so in the end we have a multi-language problem already in 8 million people. And in terms of organizational structure, it's a wild mix of public sector, university hospitals, private sector, chains, GPs, mixed models, and each of them having different IT, different governance, so it's a mess. Now, if you want to change a complicated system, there's not a one-size-fits-all way of doing it, but complicated systems you change by pushing many levers at the same time very slowly. So this is why we're very happy that our initiative is backed up both by the Ministry of Health and the Ministry of Science, so we can address the problem from both sides and slowly guide the system in a more reasonable future. So SPHN is funded via the Ministry of Science, but with the backing of the Health Ministry, and it's administrated by the Swiss Academy of Medical Science, the SIMS, and they deal with all the governance questions and the hospitals and the professional societies of the doctors. And the second mandated organization is the SIB, the Swiss Institute of Bioinformatics, and SIB deals with the research at the university side and the IT infrastructures and the coordination of the data. And this is coordinated with complementary efforts from other partners like the National Science Foundation, the Swiss Biobanking Platform, or the ETH domain, that also in their areas they all invest into the common goal of establishing personalized health research in Switzerland, and we try to coordinate these efforts as much as humanly possible. Of course, you cannot coordinate a bottom-up excellence-based research program like the SNF, because this is bottom-up calls and by excellence. Now, if I try to put a bit like where are we investing our money and for what purpose? I mentioned the hospital, so we are directly funding the university hospitals for building data lakes and organizing their health data that comes out of the transactional systems into data lakes that are patient-centric, and to standardize the way they can export the data such that it becomes shareable and interoperable. On the other side, we're building a network of secure core facilities at the Swiss high schools. That's called the Biomed IT project. And there we're building up the capacity of HPC centers that are interoperable and that collaborate in providing services, both technically as well as bioinformatics and data analytics support to the researchers that want to analyze the data. And data is not only data that comes out of the healthcare sector, out of routine care, but there's also what I mentioned before, the personalized health and related technology program by the ETH domain. And they are building up 2 big analytics centers that actually generate new research data. That's a genome center in Geneva that became operationally earlier this year, where you can do large-scale genome sequencing projects. And there is a mass spec-based center in Zurich, where you can do proteomics, metabolomics, or all kind of new technologies that are not mature yet for clinics, but they're interesting in research project to enrich the phenotype data and see what kind of new analytics do I want to do to make the next step towards either new biomarkers or new ways of characterizing a disease trajectory. Now, in the middle here is, of course, the project that use it. And the decision we took at the beginning of the project is we start by investing in the platforms and the infrastructures first, and we ramp up the science later in order to make sure that we are getting, in the end, a coherent picture and not a lot of new science silos that, again, we have to coordinate afterwards. Now, being a federal country, of course, looking at 8 million people, you would initially say, it's very easy. We just build a database in the middle, we put all the data in, we standardize, done. Now that, for political reason, is just an idea you should never mention in Switzerland without getting grilled immediately. So the only way that's possible to do it, given our legal system, is we go for a federated, distributed network of interoperable resources. Now, for the first year, when I was looking at the project, I thought, I have to change that, that's a pain, we should not do this. Now, in the meantime, A, I accepted reality, I cannot change it, but B, we can actually make a strength out of this. You know the old saying, if you can make it in New York, you can make it everywhere. I think here it's about the same. If you can make Switzerland interoperable, you'll learn a lot about the rest of the planet. So we are very much looking forward to sharing our experiences and learning from your experiences and actually how to make systems interoperable that are very dispersed and very heterogeneous. And I think this also brings us in a position to easily collaborate internationally because we're already set up with a heterogeneous network from the beginning. Now, going for a heterogeneous network, of course, creates all the kind of questions you didn't want to have in a centralized approach. And the first is finding out, where the heck is my data? And for this, we're currently setting up a network of distributed federated query systems where you can look into the active databases of the university hospitals and see, do I have enough patients that have a certain diagnosis with certain lab values that I could actually use for my study in the first place? Or is my question already just not solvable in the Swiss context? This network works technically already now. We hope to start populating it with data, so at some point in 2019 it should become online, that you for the first time have a fully integrated live view on the data of the Swiss university hospitals in one place. Now, once you found your data and you got your ethical approval to actually use it, then the question is, how do you use it? And the classical approach we're doing in phase 1 is, of course, what everybody does, is you collocate the data in the place where you normally work, and this is where your analysis then takes place, and this is also the place that ensures data security, privacy, backup, data lifecycle management. But on the long run, I think this model just doesn't scale. It doesn't scale over many legal systems, and it doesn't scale in terms of volume and data transfer. So we're in parallel working on a system that would allow distributed and edge computing type of analysis, where instead of bringing the data to the user, we send the algorithm to the data, and it comes back with hopefully sensible results. Now, everybody knows these PowerPoint slides. Nobody has seen it working in practice. So we're currently collaborating with 2 initiatives and trying to see what could be feasible technical implementations to actually make this happen. And one is an initiative here of the ETH domain called the Swiss Data Science Center, or SDSC. And they're developing a system called RenQ that promises to fulfill part of the technical requirements here, and there we're collaborating with them, defining what's really needed in the medical domain and see if the system can actually fulfill it. And we recently entered discussions with the Go Fair initiative, the personal health train implementation network, that have a very similar goal but on a pan-European level, and we'll start in the coming weeks to work out first pilot projects to see if their approach of shifting Docker containers around would actually fit the bill. And if somebody knows of a system that already does it and works, please let me know. Now, so far so good. Why is it so slow? Because this slide you've seen 2 years ago when I talked about the progress of the project, and everything is slower than you think. And of course, it starts all from, yes, we all talk about fair data, and you all know what fair data means. Fair data in health means forgotten data in some anachronistic format that's completely isolated from the planet, and if you're lucky, has some residual information content. Or maybe not, but yeah, so we are facing all kind of challenges trying to implement this when we talk health data. We talk technical interoperability, and there we see an interesting convergence, at least in our country, between what we do in research and what happens in healthcare. So we have a Bundesgesetz über das elektronische Patientendossier, or an electronic health record law, which basically says all healthcare providers have to implement interoperable electronic health records, otherwise they don't get paid anymore. Now, of course, being Switzerland, there's an opt-out for GPs, but at least for anyone who runs a decently sized healthcare provisioning unit, they have to introduce it. The law went in action 2017, so they're all now actively implementing, a little bit late, but they're doing it. Now, that sounds cool. In practice, the implementation is tough, and you even find health policy papers describing that the process is painful and is much behind schedule, but at least both the healthcare provisioning sector and the science are moving in the same direction, and it's the same people sitting on the advisory boards. So we're very optimistic that we can achieve a convergence of both systems here, so the data both feeds the care as well as the research sector. Semantic interoperability, of course, comes on top of all this. I mentioned before the complete disarray the various health organizations are, because they have different providers, so they use different systems, they have historically grown ways of doing things. So bringing all of them on a single system is completely impossible. So the way we are approaching is that we at least bring them on the same level of exporting their data. And the schedule we have here is that we're currently in discussion for the first round of variables we agree on across all the scientific projects that we are funding. This is the set of variables we need to standardize, and then in quarterly cycles we'll release new variable sets that we all agree on exporting on the same standards, in the same formats, so that we're slowly approaching a core data set that actually is shareable all across the country using the same standards. Of course, always questions about, and how is ethics and legal handled in that? Luckily, in Switzerland, we have something called the Humanforschungsgesetz, so we have a legal basis which describes in which we can operate here. And what I like about our law is that, in contrast to many others, I'm German by background, as you heard. So here the law says the purpose of this law is on one side to protect personality, dignity, and health of people, but it should also provide favorable conditions for research at humans. It should increase the quality at research on human subjects and should make research more transparent. So everything we normally talk about here, it's written in the law saying healthcare sector has to support research. So we have a legal basis now for actually moving forward. And of course, we have an ethics committee that oversees all the projects we're doing here and providing guidelines on how to move forward. And a year ago, I announced that we have a shared general consent that is used across all hospitals. Of course, 3 days after I announced it, it was scrambled again. So we're very close to again announcing the same thing. I hope this time it helps. And then what would happen is that any patient that enters a Swiss university hospital gets informed about secondary use of data and has the option to opt in. And so far, from what we see in the pilot, is that the acceptance rate is very high. And there's a lot of enthusiasm and trust by the patients into donating their data for research. Now, of course, our law has a little flaw. It was written some time ago, and it says something about signature of the patient on the consent, which they mean paper, which is something that, of course, doesn't really scale and is not transferable and is not interoperable. So we're funding at the moment a pilot project to develop something that's called a citizen-centered consent management system. And the idea here is to move away from a consent that is given at the care provider and is specific for the care provider and it's on paper, towards a system which is patient-centric, dynamic, shared. It's implemented as a smart contract on a private blockchain, so it's completely independent of any vendor or app, has a RESTful API. And the idea is, the pilot is running. We hope we can roll it out on a broader scale at some point at the turn of this year. And this should hopefully then also show the legislator that there is different ways of doing consent than doing it on paper and PDFs. I mentioned that we're investing into secure infrastructures at the various infrastructure sites at the universities. So we also finally managed to get them all operating under the same SPHN security policy all across the country. It's kind of a minimal standard for now. It still needs a bit of polishing in terms of usability, but we're moving to an ecosystem where we can actually have the excellence in research we have at the universities brought together with the richness of the data we're getting out of the healthcare sector, and then opens the avenue for really exciting data analytics and bioinformatics. And I think in that respect, we're really blessed here in this country having a lot of research groups with great expertise in that area. So far I've been talking about infrastructures. Now infrastructures is something that people like to build ivory towers, and they're pretty useless typically, but they look beautiful. So we have to make sure that we somehow push the envelope both technically as well as scientifically, and the whole thing makes sense. So we have bottom-up calls for two types of projects. One are development projects. It's pushing the envelope of what's possible and overcoming bottlenecks. And one of them I just presented before, the blockchain-based consent management system. And the other type of project are driver projects. Driver projects are there to test drive whatever infrastructure and governance process we're building, with the idea that all this picture here actually gets glued together, and we really test, does the interoperability work? Do we get reasonable scientific results out of whatever we are building here? And this is the outcome of the first round of projects we're funding. And you see, it's a very broad spectrum. There's people that just look at health data to find new signals of frailty in elderly patients. There's the mandatory oncology, personalized oncology treatment and panel discussion. Also to mention the last one I find very interesting. This is one where the project tries to read the signal from intensive care unit and make prediction if patients are on a trajectory of developing severe sepsis cases and get early signs of sepsis so the treatment can start earlier. So it's a very broad spectrum from rather simple data integration to rather data heavy and real-time relevant projects. And they hopefully help us to test drive to a point where this all fits together. Now, to make sure that the projects actually talk to each other, they use standards that are internationally accepted, that it all kind of fits in the end in terms of dependencies. There's a central coordination that's called the SPHN Data Coordination Center, and their task is really to make sure that this whole network, as complex as it is, in the end all moves synchronously in the same direction. So what is missing in this picture? We had a call for proposals this year where we tried to address a few of the areas where we haven't done anything so far. One is in terms of imaging and interoperability of radiology. The other one is public health and healthy citizen. We have focused so far on university hospitals. Now they normally see patient when it's, sorry to say, but too late. So we have to really move earlier towards the healthy citizen if we want to develop in terms of also prevention. And we haven't yet addressed the interoperability with the already existing cohorts and registry. And this is something that came out in this call. But the real missing piece or the pink elephant in the room is there is no Swiss genomics strategy. This is a small country, it's pretty rich. There's no reason why in 10 years we shouldn't have our own genome for every Swiss citizen, but there is neither a plan nor a strategy. I think this is something we really have to work on in the coming years, and I hope that the discussions with this forum here will help us to find the right way of actually moving forward with this, because we're really lagging behind. Even so, we have the whole other initiative on all the rest of the data, the genome part is really very weak so far. So conclusion, we're a small country. The only way we can survive is by using international standards, internationally collaborating, being a good citizen and working with all of you, moving forward to also bringing Switzerland at the forefront of personalized health research, but also having impact on how the healthcare sector works. I'd like to thank our funders First, the canton of Basel-Stadt that started funding us at a point when there was no decision at the level of the national government because they believed in the idea and made the kickoff happening. Of course, the two ministries that are funding us via the SIMS and the SIB. But specifically, I want to thank the team at the Data Coordination Center. And there, Sabine is somewhere? Yes, so Sabine is the person that is behind organizing the meeting here, doing all the logistics and making this all happen. And without Sabine, I think we all wouldn't be here. So thanks a lot, Sabine. Okay. That's the end. If there's any question, I'm happy to answer. If you need more information, they're all on our websites. Just one last word. If you like Basel and if you like the project, we actually would like to work with you, so we're hiring. Feel free to approach us. Thank you very much. Yes.
Yeah. Thanks so much, Torsten. That was amazing. I was really interested in the multi-language issue that you need to deal with. And particularly as yesterday we were talking about capturing clinical phenotypes and ontologies. Can you just give us a little bit more detail of how you're dealing with that multi-language issue?
In very different ways. So of course one way is to go towards controlled vocabulary SNOMED type. And there we have projects for translating SNOMED terms into the various national languages. There's the first 6,500 terms that are translated, and we're now trying to ramp up to a broader coverage. But of course, that only solves the problem halfway around, because then still you have to translate the free texts into controlled vocabularies. And that seems to be working well in English. It's kind of working a bit in French, because Christian Lovis has worked a lot on this. Italian, it's a blank. German, we haven't started working on yet. So there is challenges in doing the automated term translation and annotating them. Now what we're doing in parallel is there is a project in pathology where we're trying to invert the game. So the pathologists of the country have come together and decided that instead of writing reports in text and afterwards we do text mining to code them again, they will code first and then generate text from the structured reports, and that of course solves the language problem. It's a bit of a cultural change because many medical areas are not ready for it. I'm very happy that the pathologists are playing the guinea pigs and showing it once how it can be done, because that would really solve the problem. And they have last week rolled out their first pilot and they all signed up to use structured reports from now on. So we hope we have a use case that we can show to other domains that actually this way around makes more sense than capturing from the other side.
Yeah, thank you. Could you tell me how you've managed redundancy within the network? For example, one patient who moves between two different cantons?
Very good question. Short answer, not yet. It's on the roadmap for the coming year. There's two discussions at the moment. One is some kind of probabilistic linkage that brings together the various records, which I'm desperately trying to avoid. We're in discussion with the health ministry if we can use the national patient ID or the social security number in some form of encrypted, hashed way, having a national data linkage center that brings it together for projects that have ethical approval. So I think we're definitely, from a legal situation, not allowed to use a national patient ID and just share it across the network. So we have to go via a trusted third-party approach. But if we implement this well, we think that it's not really something that hinders you massively. So the hope is that by just linking it via the third-party mechanism, we can link the data sets together without impeding the science and still staying within the current legal framework. And that then should allow us, I wouldn't call it duplicates, it's actually the opposite. It's you have a patient trajectory and you want to group the trajectory together in one data set rather than having them separate. But yes, very good question.
What's the attitude, the approach, the engagement of Swiss citizens? I think you had it on a slide, but is there a push for this, for better healthcare, for better use of data from the citizens?
So we don't feel a strong push towards that, in the sense that people seem to be very happy with the quality of care they're getting. Because there's no waiting list for anything. There's not a single treatment that would be declined to a patient if it makes medical sense. So if your doctor diagnoses something that looks like a rare disease, health insurance would cover whole genome sequencing, no questions asked. So in that sense, there's no push from the patients because they don't feel the need. They feel they're well cared of, but there is a very strong trust in the system. So if you come to the patient and say, look, we're treating you and this is what we do for you, but we would like to use the data that is generated for secondary use in other research projects, we get very high acceptance rates. So there seems to be this level of trust into the system that it works and that you can also allow the data to be used further on.
And added to that, as you've got a certain level of exomes and genomes being done now, as you say, you know, I think it's on the list of things you can do. Is there any sense of coordinating the current genomic assays that are happening in Switzerland? You said there wasn't a genomics strategy. Do you think the genomic strategy is best done top-down, or is it best done saying, for these classes, you know, the data should be sent in a federated but accessible way for research or something like that? Which way is the better way to do it? From the insurance schemes up and reimbursement up, or from a program down?
I think it's both. The bottom up is the only thing we can do at the moment because we do not have a centrally funded large-scale sequencing project, so we'll have to make sure that whatever is done at the various sites gets combined, and there are several projects in SPHN that in specific disease area do exactly that, like in the oncology range, they're working on bringing it together. In the infection biology, they do the same. So this is one way of doing it. Now, what I said before, nevertheless, if we have as an ambition, say, we actually want to have the genome as a kind of passive background information for better healthcare in the future, that's not the mechanism that will work. So if you want to take a bolder approach saying, I want my genome just to be more proactive in deciding how treatment should be done, I think we need some kind of coordinated top-down way of doing it. But we hadn't yet a good idea on how to implement that. Okay. So we're still staying at the bottom up.
Great. Let's thank Torsten again. Thank you so much. And Torsten, really, thank you so much for being such a wonderful local host.